Okay, a lot of people are online today, so let's get started. Hi, good morning. Welcome to Pediatric Grand Rounds. Today is a special day because we have one of our speakers who is Zooming in or WebExing in remotely with us. But here in the room with me today is Dr. Shannon Staples. So I will introduce her, she'll introduce our speaker, and as usual, if you have questions or comments at any time, you can enter them into the chat box, and I will be watching the chat during the presentation. So today I have the pleasure of introducing Dr. Shannon Staples, who's worked as an attending ER physician here at Seattle Children's since 2001. She's always been interested in adolescent, reproductive, and mental health, but recently joined the Seattle Children's Hospital Trafficking Work Group and trained in the West Coast Children's Clinic Commercial Sexual Exploitation Screening Tool, which is to be used here at Seattle Children's. Welcome, Dr. Staples. I'll let you take it from here. Thanks, everybody, for being here.
Good morning. I am excited to be here to talk about a topic that I feel very passionate about, and at Children's we've made some great strides in identifying kids in our community, so I'm excited to hear what Dr. Greenbaum has to say to help us continue our work. Dr. Greenbaum is a retired physician specializing in the area of child protection. She worked as a senior vice president of survivor care at Our Rescue and is the medical director of the International Center for Missing and Exploited Children. She's a past medical director of the Stephanie Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. Dr. Greenbaum is a board member of the International Society on the Prevention of Child Abuse and Neglect and a past president of the American Professional Society on the Abuse of Children. She provides global training and technical assistance to health and mental health professionals, social workers, law enforcement officers, prosecutors, judges, and educators to improve the community response to child sexual abuse, improve the community exploitation and human trafficking. Her training is interactive and very practical, focused on implementing a trauma-informed, rights-based approach to working with children and families who've experienced trauma related to sexual violence, human trafficking, and forced migration. I'm gonna go through a little bit of our work here at Children's just to set the setting before Dr. Greenbaum takes over. So, exploitation in healthcare settings. 88% of human trafficking survivors report having had contact with a healthcare provider, which is a staggering number, honestly, to think that we have so much contact with these humans. But only 6% of healthcare providers report treating a survivor of human trafficking at some point in their careers. And this is part of what we're trying to change, right? Within our own division, I feel like we started this work like 3 or 4 years ago, and most people, when we asked, have you ever treated a victim of human trafficking, most of the attendings said no. And now if you ask, almost everybody says yes. And it's not that the victim number has changed, it's that our awareness has changed. And so we have been able to really make a difference in our community to see the kids and recognize them and then give them the resources that they need. So these are some examples of trafficking in our own environment. Actually, this patient was mine. A 15-year-old girl had sex with multiple teens to pay off her boyfriend's drug debt. So part of what happens when you ask these kids the question, are you being trafficked? They say no, because they will tell you this is volitional. They are choosing to do these activities. 13-year-old male sends nude photos to an adult man online in exchange for the adult man's promise that he won't tell anyone that he is gay. So this is one of these sort of slippery slopes where he befriends a person online, they start talking, he exchanges some photos, and then the guy says, well, if you don't send me more photos, I'm gonna tell your family that you're gay. And so the child will continue to send photos and be exploited because they're worried about what their family's response will be. And that patient came in with suicidal ideation because he couldn't see his way out of the problem. Another one, 16-year-old male exchanges sexual acts for marijuana. So this was a kid who denied it, even though when we pointed it out that what he was doing was that he was being exploited by an adult. He said, well, I wanted the marijuana, so I was willing to do and this was in the parking lot of like a 7-Eleven, basically. This kid would go to the 7-Eleven and meet the guy to get the marijuana. And then 13-year-old females offered housing and food by an adult male in exchange for sexual acts with multiple people. So there was a case recently where the girl was homeless and her friend said, oh, I know somebody that you can stay with. He'll offer you shelter if you'll have sex with him. So these are some different scenarios that we have experienced here at Children's. And part of being here today is just to continue to raise awareness and help bring more people into the eyes of trying to find these kids and help them with the next steps. There's one slide about King County data. I'm not going to read it all, but I think it's really profound to look through it and see that it's mostly female, it's different races. These children are young, 14.4 years of age at the first encounter. A lot of these kids have already been sexually abused. A lot of kids are living on the street, face homelessness. So these are our most vulnerable youth in this scenario. And we see these kids, we see them, every day, and our job is to try to identify them and get them more services, really. At Children's, we have a team, the SCAN team, that are the experts for any CSEC concerns. So we have a workflow. You can see it over there on the side. It's part of, you can find it on Child. It's part of the different workflow patterns, algorithms that we have on the computer. So SCAN also participates in multiple community meetings to bring awareness to the different organizations that we're working with throughout the community. And then the SCAN social worker, there's several of them. They are available to help us out. We can call them anytime to ask for resources. They follow up on these kids. There's a database that people keep to see how many times the kid has touched the system too, and to try to sort of help keep track of how these kids are doing and get them resources when they do come into care, because it takes multiple times usually for a child to come into care before we can really make a big difference with the situation. I'm ready now, Dr. Greenbaum, I'm done. Thanks.
Okay. I'm Jordan, and I'm very delighted to be here, and thank you so much for having me. I'm looking forward to an interactive hour talking about really one of the topics that's near and dear to my heart, which is child sex trafficking and exploitation. I'm hoping at the end of the talk, you'll be able to describe some common conditions under which you may see patients who are experiencing commercial sexual exploitation or child trafficking, how they present to your healthcare setting, be it a clinic or an emergency department. And you'll be familiar with 2 screening tools that are available for identifying patients at risk for trafficking. And that you'll be able to summarize several components of an appropriate clinical response. And we have about 5 resources available for you to sort of help supplement this talk. And those will be available to you at the end of the session. I have a lot of links that will help sort of flesh out what we talk about here, because this is a pretty brief presentation. As you probably know by now, the federal definition of human trafficking involves 3 components: an action, a means, and a purpose. You need to show one item from at least these 3 categories in order to show that somebody has been the victim of human trafficking. There is an exception, which is important for today and for you and me, and that is when we're talking about sex trafficking of a minor, anyone under 18 years of age, you do not have to show the means. You don't have to demonstrate that there is force, fraud, or coercion. There almost always is. It's subtle, but it can be, it's usually there, but we don't have to show it. And that means that children who say, I decided I wanted to sell sex in order to get a place to stay. It was my decision. Nobody forced me. I went out and did it. They are still experiencing child sex trafficking because there is the exploitation, commercial sexual exploitation. We do not have to show force, fraud, or coercion. This is not the same for child labor trafficking, incidentally, which does require force, fraud, or coercion to qualify as labor trafficking, simply because, as you know, children are able to work legally, and so they're to be trafficked, you have to have the means of force, fraud, or coercion. When we talk about commercial sexual exploitation, here in the United States, it's often used interchangeably with child sex trafficking. They're almost the same definition. There's some state law variations that make, in some cases, a certain act may be considered exploitation in one state and trafficking in another. But for all intents and purposes, they involve a commercial sex act with anyone under 18. A commercial sex act involves the exchange of a sex act for something of value, money, drugs, shelter, luxury items, what have you. I'm not going to spend a lot of time on risk factors. The risk factors that was shown by Shannon just now really sort of correlate very highly with what is seen in the United States and globally. And you may, as you're doing, say, a heads exam, may identify some of the risk factors at the individual relationship level, such as a history of prior sexual abuse, family poverty, intolerance of LGBTQ status. You may even be aware of some community factors, knowing where the child lives. That may be in a community where there is a lot of commercial sexual exploitation going on, many strip clubs, for example, and it's highly tolerated. Or there may be high crime rates, and there may be community risk factors. The societal risk factors are more or less not in you and I's control at this point, but it's good to know how risk factors way up the societal level can condone or even encourage trafficking. Let's take a couple of examples. Louisa is a 10-year-old female. She lives in a small industrial town. The manufacturing company that really employed most of the town's adults closed, and her mother was laid off, as were many adults in the community. So now the family is facing eviction. The mother tells Louisa to, quote, go with the landlord, do whatever he wants you to do. And that involves once a month, Louisa has to go to the landlord's apartment. He takes pictures of her naked, molests her, takes photos, and she essentially is a victim of sex trafficking. Kat is a 16-year-old transgender female who ran away from home to get away from mother's drug addiction and mother's violent boyfriend. Both the mother and the boyfriend are very intolerant of her transgender status. She lives on the streets and exchanges sex to pay for food, hormones, and clothing. Now, she would tell you that she's doing this on her own, that she's in fact exploiting her customers to get what she needs. But in fact, she's less than 18, she's selling sex, so exchanging a sex act for something of value, and she's a victim of sex trafficking and exploitation. We don't have good prevalence numbers of child sex trafficking. The World International Labor Organization estimates global forced labor at 3.3 million children, of whom about 2 million are victims of sex exploits, commercial sexual exploitation. Numbers in the United States are just not good. Most of the studies that are done in individual areas or with individual populations, such as the homeless and runaway youth you see here. So we really don't have good statistics at this point. You may see children who have experienced trafficking and exploitation due to a number of health and mental health impacts. Violence is very common, so you may see somebody for allegations of physical assault or sexual assault, or you may notice inflicted injuries during your exam. That may not be the chief complaint, but it may be what you notice on exam. Sexually transmitted infections are extremely common. In our study in Atlanta of sex trafficked adolescents, about 43% of them had active STI at the time we had assessed them, and a third of the patients had a prior history of an STI. So very common to have sexually transmitted infections or a history of infections. Pregnancy is also very common among adolescent youth, ranges between 25 and 30% of the history of pregnancy at some point are documented in the literature. Drug use, very high, again. About 88% of our youth in our study reported using drugs, and many of those reported using many polydrug use, often as a way of self-medicating to get away from their stress and anxiety and emotional distress. Many also have untreated chronic medical conditions. Despite seeking medical care, they may not seek primary care and ongoing care for chronic medical conditions. So we may see, you and I, in our urgent cares or emergency departments, may see children for exacerbations of chronic diseases, late presenting infections, diabetes complications, asthma complications because they don't have their treatment. And once children are removed from their situation, there can be long-term chronic health complaints, typically fatigue, chronic pain, and other things such as that. The mental health impact is at least as important, if not more, than the physical health impact, I believe. Very high rates that you've reported in your county, but also globally and throughout the United States, children who have experienced commercial sexual exploitation, trafficking, report very high rates of post-traumatic stress disorder symptoms or full-blown disorder. They have high levels of depression, and multiple studies, high levels of suicidality reported. In one study from the Midwest, about 50% of adolescents reported attempting suicide within the past year of their sexual exploitation experience. Lots of behavioral issues related to trauma, and these often manifest as hostility and anger and behavioral issues, antisocial behavior, etc., anxiety disorders. And then, as we reported, many report substance use and misuse. Lots of behavioral problems, which may be why you are seeing the child. Oppositional defiant disorder, for example, suicidality brings the child to the emergency department. Problems with chronic memory loss can be also reported as a health complaint. Well, let's get to our two examples, Pat and Louisa. How do you think they may present for healthcare? Where and how and with whom? The answer to that is that they may present anywhere, in emergency departments very commonly, public health clinics, teen clinics, Planned Parenthood. They may present to their own private pediatrician or to their own chronic care specialist or to a surgeon. The most common places are emergency departments in public health or general teen clinics, Planned Parenthood, etc. And they may present alone, or they may present with other children who are experiencing sexual exploitation. They may present with family members who may or may not be aware or even involved with the exploitation, or they may present with other people involved in the exploitation, traffickers or other children involved in trafficking. So there can be a variety of presentations, and they may present with any of the health conditions that we just talked about, or the mental health conditions. Spontaneous disclosure of trafficking and sexual exploitation is extremely unusual, but that doesn't mean that children won't talk about it if we ask them. But we need to know who, among the thousands of patients you see every day and every week and every year, how many of those are at risk for trafficking. And there may be some indicators that may clue you in that this particular child you're dealing with right now may be at risk for trafficking. These are some of the what we call soft indicators that are indicators reported by survivors of sex trafficking. Many children who experience trafficking and exploitation are moved from city to city to city. So they may be unfamiliar with their surroundings and may end up the first night that they're there in Seattle, they may end up either in a hospital, a victim of assault, for example. And when you talk to them about where they're living, they may look very sort of confused because they don't know the city, they don't know the surroundings or even where they're staying. They may be in the presence of someone who appears to be very domineering, intimidating to the patient, domineering towards you, maybe even intimidating towards you. They want to control the conversation. They don't want the patient to talk. This may be a person who is part of the trafficking organization and may not want the child to disclose any information. So they want to control the situation. They may provide you, or the child may provide you, with inconsistent information, especially when asking about injuries or delays in seeking medical attention. Why they're coming in so late. There's been 3 days of pelvic pain. Why are they waiting so long? They may give you inconsistent information. Or you may notice possible indicators of trafficking in the course of your taking a social or medical history or reproductive history, or during your exam. You may notice things, come upon risk factors, for example, or they may present for concerns about sexually transmitted infections or pregnancies. You may realize that this child has a history of prior pregnancies and terminations of pregnancies, or a current or past history of sexual assault. So things you may notice in your history or physical exam may alert you to the possibility that this child has many of the associated factors associated with trafficking, and that may lead you to explore that possibility. Let's talk a little bit more about identification of at-risk patients. We don't need to consistently totally rely on possible indicators. Those are very helpful, and we should not ignore them. We should follow up on them. But there are also ways that you can screen for risk factors. Now, there are many screening tools available, but very few have been designed for use in the busy healthcare setting, where you need something quick, rapid and reliable, and designed for the healthcare setting. There are a few screening tools which we're going to talk about in a minute. Keep in mind the goals of your screening tools. If you're going to screen, we need to know why we're screening and how we're screening. In a healthcare setting, I would argue that we are not screening to identify with certainty children who have been trafficked and exploited. Instead, we are screening for risk factors. We want to know, is this child at high risk for trafficking and exploitation? Because if they are, we need to find out what their risk factors are and provide resources if they're interested. And we may need to report this to authorities as mandated reporters. In most, if not all states, we are mandated to report suspicions of child sexual exploitation, including Washington. So we don't need to be certain. In fact, we don't want to wait until we're certain that somebody's been exploited to take next steps. I would argue that a child who was at risk for trafficking has virtually the same needs as those who's actually exploited and experiencing the exploitation. So we're assessing risk and assessing needs so that we can offer resources. That's the point of screening. With that in mind, there are several short screening tools. The short screen for child sex trafficking was developed by our group several years ago and was developed based on healthcare research in a healthcare setting. And so we developed this tool in the healthcare setting. It's got 6 questions. It's validated in emergency departments, teen clinics, child advocacy centers, et cetera, for adolescents 11 through 17, up to your 18th birthday, and with males and females. It has not been validated in specific groups such as Native American patients or unaccompanied migrant youth. So it's generally in domestic emergency departments and teen care centers. And it screens for risk factors for child sexual exploitation. There's also a quick youth indicators of trafficking, which was not designed for the healthcare setting, but is nonetheless very short, and it screens for risk of labor and sex trafficking in young adults, 18 to 22 years of age. It's got 4 questions and was designed in the homeless population. And then we have the rapid appraisal for trafficking, the RAF tool, which was designed for adults in an emergency department. It's got 4 questions and screens for labor and sex trafficking. Those are the very rapid ones. Again, the short screen was designed for the healthcare setting for children. And just looking at that a bit closer, that has 6 questions, which can be administered via written forms, electronic forms, or verbal forms. The questions get at these risk factors. They don't use this wording, they use wording that's very normalizing trauma-informed. So they don't just say, what's your drug alcohol use in 12 months? They phrase it differently. But the risk factor is drug or alcohol use in the past 12 months, history of running away from home, any history with involvement with law enforcement, history of broken bones or being knocked unconscious. That turned out to be a risk factor in our original research study. A history of sexually transmitted infection, or history of more than 5 sex partners in a lifetime. If a child answers yes to 2 or more of these questions, they screen positive, which does not mean they are unnecessarily being trafficked. It means they're at risk of trafficking. And so they need a second tier of more in-depth questions that are often done either by a trauma-informed trained healthcare provider or a social worker who follows up on each of the positive screening questions. For example, if you say, yes, I've run away from home I've had a history of running away from home, the follow-up by the social worker might be, tell me about the last time you ran away from home. And that open-ended question allows better assessment of the true risk associated with the runaway episode. If the person says, I ran away for 2 hours because mom wouldn't buy me a prom dress, that's not a real risky situation. But if they say, I ran away from home because of being sexually abused, I stayed out for 3 nights to a week, that's high risk. So the follow-up risk assessment really is free, open-ended questions exploring the level of risk and identifying possible resources. Some people don't screen in the emergency department or the clinic. They may instead provide universal education or resources, which is an alternative to screening. Futures Without Violence publishes these very short little brochures you see on the right here that look at healthy relationships. They introduce the idea of trafficking and how violence affects health. They do not ask screening questions. The idea is for universal screening within a population. Every patient within a population gets 5 minutes of universal education by the healthcare provider, where they explain these little brochures about healthy relationships and violent relationships and human trafficking. And then they ask, would you like these brochures for you or a friend? Here are some national resources for you. Would you like to talk about this more? And that opens the door for somebody who wants to talk about it, but does not screen for those individual risk factors. So it's a different approach. Well, let's look at the trauma-informed approach to care. How do we work with patients who we think may have been exploited, abused, trafficked? How do we do that? You've probably heard of the trauma-informed approach to patient interactions. It's basically a way of interacting with patients that was fully explained and laid out by the Substance Abuse and Mental Health Service Administration in about 2014. This is their approach, the trauma-informed approach. And again, it's sort of like a way of interacting with people who have experienced trauma in their lives, which is just about anybody, but certainly people who have been trafficked and exploited have experienced a lot of trauma in their lives. There are several key components to this, which I like to focus on. One is, and perhaps arguably the most important, is that a trauma-informed clinician is sensitive to how the patient's trauma in their lives has impacted the patient's feelings, their thoughts and cognitions, and their behaviors. Being exploited and trafficked certainly is an ongoing sort of chronic trauma that's going to impact the way the child sees themselves, their self-image, their self-esteem, their sense of self-agency. It's going to affect how they view the outside world. Probably now they view it as a hostile place where everyone wants to exploit them, and no one, especially adults, can be trusted. That's going to affect how they see you as a healthcare provider, how they interpret what they say, what you say, and the things they say to you, their beliefs about you. They don't trust you. They don't trust us. They're expecting the worst. And the things that they say are going to reflect that view. Their behavior may reflect the trauma. They may have learned, having been in a hostile environment for 2 months, 6 months, 2 years, that they can't trust the world. So they're very guarded, or they're very hostile. They're very aggressive. They're very sarcastic with you. They may be on the other hand, very anxious, afraid, withdrawn, depressed. These are traumatic stress responses to the trauma they've experienced, and their adaptations to a very hostile environment. But if we can understand that and say to ourselves, this child's sarcasm, her aloofness, her hostility towards me is not personal. It doesn't mean they don't like me or they don't like this hospital. It's her way or his way of dealing with what they've experienced. The best defense is an offense. The best way to avoid being singled out and traumatized is perhaps to not make eye contact, to withdraw, to be very submissive. Perhaps being sexualized is an adaptive behavior from months of being sexualized in the sex trade. If we can understand that, it's much easier for us to respond in a trauma-informed way, which would be to be empathic, non-judgmental, calm, and open, not to meet a patient's hostility with defensiveness or rejection on our part or hostility on our part, but instead to be very calm, open, empathic, and try to build safety, a sense of psychological safety and trust that allows that child to eventually drop all those barriers and tell us what's on their mind. We have to constantly be building a sense of safety and trust by building rapport and making it very clear that we care about the patient, we're listening to them, we care about their point of view. We need to provide information, be transparent. It's a basic human right. An individual needs to have information about anything that's going to impact them. So we need to make sure we tell them why we're asking sensitive questions, what the exam involves, exactly why we want to do diagnostic testing, the pros and the cons of the testing, the pros and the cons of treatment, so that they can understand and know what is going to happen. And whenever we can, give them the choice. Ask for their consent. In anything that is not mandatory, we want to ask for their consent and respect them. So ask for the permission to ask sensitive questions. Ask for permission to do an exam. Ask for permission to do diagnostic testing. And we need to respect their privacy and confidentiality, making it very clear what the limits are of confidentiality. An overriding concern in the trauma-informed approach is to always keep the child's best interests as the highest priority. You know, when we are working with children who have experienced sexual assault or physical abuse, we have our agenda of things that we need to do. We need to do an exam. We need to do maybe an MRI of the head for an infant, a sexual assault kit for an adolescent, et cetera, et cetera. Test for sexually transmitted infections. We have all this list of things we want to do. But those are our priorities. The police have their list of priorities. They want the rape kit. They want to interview the child. Everybody around the child has their list of things they want to do, but that all has to take second priority to the best interest of the child. Tonight, in the middle of the night, it may not be the best time to get a sexual assault evidence kit on the child. Even though we need to do it, it may not be the best time. So we need to think of what is in the best interest of the child. And respect that as much as we can. If they don't want a sexual assault exam, we cannot and should not force it unless there is a medical emergency. If they don't want a sexual assault evidence kit, we should not force it. We need to respect the rights of the child as much as we can. When I say it's all about safety, a couple of just key tips for you to keep in mind. In order to ask children questions and for us to explore ways we may be able to help them and find out what's on their mind, what their vulnerabilities are, we need to separate them from whoever they're with, because we can't take the chance of asking sensitive questions about their lives in the presence of someone else who, for all we know, may not have the child's best interest in mind. It may be a parent there, but the parent may be involved with exploitation or trafficking their child. So we need to take time, developmentally appropriate, according to the age of the child, take time to meet with the child alone. And you can often incorporate this into your introduction. Perhaps the person who brings the child back to the examination room starts by saying in the waiting room, you know, we need to speak to all of our patients alone. That's our policy here. It's our practice here in the emergency department of the clinic. So I'm going to bring John or whoever it is, the patient back to the examination room, and we're going to have a chance for him to talk to the healthcare provider, and we'll come back out and get you, mother, or whoever the person is with Dijon. We'll come back out and get you in a few minutes so that you can join us and we can all talk together. And I can talk to you as well alone. But initially, we're going to talk to Dijon alone. You're setting this as a practice that goes with every patient. You're not signaling anyone out. You're just saying, this is what we do. Or if there is a lot of reluctance by the companion to leave the child alone, you could, on the other hand, remove the child from the examination room. Say, I need to take this child to the bathroom to get a sample, a urine sample, or to get an x-ray. You remove the child and take them to a private place where you can talk. You want it to be a quiet, warm environment where you can take a little bit of time. It does not have to be 20 minutes, it can be 5 minutes, but take time to build rapport. And you can do that by attending to their basic needs. Are you hungry? When was the last time you ate? Sophia, would you like something to drink before we get started? Gee, it's kind of cold in here. Are you warm enough? Would you like another blanket? That conveys that I care about the child's basic physical needs. It starts to break down barriers, build rapport. How are you feeling right now? Have you been to the emergency department before? Tell me about the other times you've been to emergency departments. Or, talk about school or something for a few minutes to let them know that you're making good eye contact and that you care. How do you provide a trauma-informed exam? You probably do a lot of this anyway as you are working with any patient, but some of these things may be new. And it's extremely important to realize that a child who has experienced sexual exploitation or trafficking is probably going to be traumatized by the genital exam. It is not something that they can do without any feeling at all. So be cognizant of that. It's likely going to be very hard. So we want to monitor closely how the child is doing throughout the entire exam. So you're going to want to start with reiterating what the exam entails in detail and why it's important to do it. And then get permission. Is it okay if I do the exam? The child may agree to parts of the exam and not other parts of the exam. So we try to work with what we can. We would want to ask the child, who would you like to be present during the exam? You're going to want to have a chaperone with you because you don't want to be alone with the child in the exam room. AP policy, excuse you. But we want to ask who they would like. Now be careful here. If you have concerns that the person they're with is involved in the trafficking, preferable not to have that person in the exam room. So you might want to say, we're going to have we're going to have the nurse with us today, and she'll be with us for the exam. You're going to want to explain each step, obtain consent, ask permission to touch the patient. Okay, you've given the consent for the exam. Is it okay if I touch you now? Would you like me to start at your head or at your toes? Which would you prefer? By doing that, by asking that question, I'm giving the child choice and control. She says, start at the top. Okay, can I touch your head now? Yes, okay, now you touch. We minimize the body parts that are exposed at any one time. We're very careful to keep the breasts and genitals covered as much as we can. You might want to tilt the head of the bed during the genital exam so that you can watch the child's face and see if they are having difficulty and look at their emotional expression. Also, the chaperone should be very aware and paying attention and letting you know if they sense any discomfort. Monitor for distress. That may be sort of uncontrollable shaking of the legs sometimes is seen. It may be withdrawn and being very tense. You'll get a sense of distress. At the end of the exam, you're going to want to explain your findings, especially the genital exam. They want to know what you saw. So explain the findings, explain the meanings. Ask if the child has any questions about that. This may be the time when the child can ask questions and you can allay specific fears. Children may have erroneous beliefs about things that, since I've had sex 100 times, will I ever be able to have children? Yes. So you want to explain those, alleviate fears, and talk about myths and dispel myths. So those are some ways that you can interact during the exam, and take your time during the exam. Take time to stop and say, how are you doing? Are you okay? Should we go on? Yes, let's go on. We're almost done. I used to say during the genital exams, we're about a third done. You doing okay? All right, let's keep going. We're almost done. How are you doing? So that sort of breaks it up a little. Reporting and referrals. I just want to talk a little bit about this. Know your mandated reporting laws. And we are mandated reporters in Washington and other states. If you suspect commercial sexual exploitation, we're mandated reporters. It's important, however, that you don't make that call to authorities without letting the child know, because we don't want to betray the child. So tell the child what you're going to do. Talk to them. They may really object. So instead of saying, oh, don't worry about it, I'm going to go do it, say, tell me more about what worries you. Why are you worried about this? So that you can understand and perhaps work with the child. They may tell you, because it's not safe, because da, 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 and that may be important information. So listen to their concerns, try to work with them. You still have to make the report, but what you can do is say, I'm going to still have to make the report, but you and I can work together on how we make the report. Let's talk about how best to do that. Would you like to come with me when I make the call? Would you like me to make it from this room? Would you like me to do it and you to be on the speaker? Would you like to make the report? How do you want to do this? So that they feel involved and you are empowering them. You still have to make that report, but allow them to take part if they want to. Be transparent, engage the child. When you are screening or when you're talking to the child, doing your heads exam, you've probably identified some needs that the child may have, things that may address some of their vulnerability factors. They're living on the street. Maybe you have as a social work list of homeless shelters or crisis lines, etc. You're full of ideas. Before you share those ideas, you ask the child, what do you think would be the best way to help you? What would be best for you? Once you leave this clinic, the emergency department, what do you think you need? Get their opinion. What would be the best for you? You're the expert on yourself. You know better than I do what would be best for you. What do you think would be best? And so the child may say this or that, and you explore that with them. Then they may say, I don't know, what do you think? And then you say, well, I've got some ideas based on the information that you really generously provided to me. I've got some ideas. I'd like to share them if you want to hear them. Yes. Now you can bring out your ideas. Well, there's this homeless shelter, Covenant House, da da da. Have you heard of that? And the child says, yes. And I've heard, good things or bad things or whatever about it. So you ask them, what do you think about that? You're engaging them and empowering them. You share your ideas, but not before you ask them for their ideas. Be careful that if they say, yes, you can make referrals, we don't want to give out any private information without express permission to do so. So keep in mind the HIPAA rules. Respect confidentiality and obtain consent as necessary. But the key thing is to engage the child as much as you can. Just to conclude, children and youth who've experienced trafficking and exploitation have undergone very difficult circumstances. And so their behavior, their beliefs, their thoughts, the things they say may present challenges to you and may seem maladaptive, they may seem out of place. But we have to realize that those are responses to trauma, and we have to respond to them in a trauma-informed way. Being non-judgmental, open, empathic, asking for more detail, allowing them to talk more than we talk, getting their side of the story and listening to them before we speak. That's a trauma-informed way. And so we need to use trauma-informed care and actively engage the child, give them information, seek their consent, encourage a sense of psychological safety. We have plenty of resources if you're interested in learning more about trafficking and the healthcare response. Let me go to the next slide. Second slide. Here are 5 resources that are available. One is the National Human Trafficking Resource Center, which is a national hotline which can do some crisis intervention. They can answer your questions if you have them. If you're anywhere in the 50 United States, you can call them at any time or text them. The number is at the right upper corner here, the trafficking hotline, and the text number as well. They're open 24/7 and they have interpreters for 200 languages. There's also an AAP clinical report on the healthcare provider response to suspected child trafficking and exploitation that really takes you through in much more detail what we've covered today. There's also a human trafficking toolkit that is in English and Spanish. It's available at this link that I will send you the PDF, or you'll get the PDF of this talk. You can click on the link, and it takes you through how you can assess your current healthcare setting on the state baseline status of your services for children who have experienced trafficking, and then provides ways that you can improve your services, both for adults and for children in the healthcare setting. So it takes you through a baseline assessment and then guides you through recommendations and free online resources that can help you improve your program. There's another, number 4 is a how-to guide and how to develop a healthcare protocol for your emergency or emergency department or clinic if you're interested in developing a protocol. It takes you through steps to do that. And then there's a 5-session online course on the healthcare response to human trafficking. All 5 of these are free and available online. This is my contact information. Please feel free to reach out at any time. If you have trouble with accessing any of the 5 resources, just go to the ICMIC Health portal at this website here, because they're all there on the health portal. And you can also reach out personally to me and I'll help you through it. So I'd like to open it up for questions, and thank you so very much for participating now today. Hand it back to the hosts.
Thank you. Really important and serious topic. And I'll open things up to questions in the room, and then also for people online, you can put your questions in the chat. Thanks. Okay, I have a question for you, Dr. Staples. Yes. Can you talk about the work that you're doing with the committee here and what your hopes are for Seattle Children's screening? And then you can ask your question.
So my hope for today is that this will raise awareness so that we can identify more and more kids. We have been using a trafficking tool that came from West Coast Children's Clinic in California. We've experienced some barriers with this tool because you have to be officially trained either through that clinic or through Train the Trainer here at Children's. We initially trained a fair number of people, and then through attrition, a lot of those people have moved on into other jobs or left the organization. And so we are at a very few number of people who are actually trained to use this tool right now, which has put our work group in kind of a bit of a crisis. So I took a lot of pictures of your slides, Dr. Greenbaum, because I feel like I'm going to go back and look at them and see what we can do. Dr. Greenbaum also has a series of questions that we have been using. They are intense questions. That's probably a pretty good word for it. They're very important. They're validated. They're amazing questions. But a lot of people have trepidation about asking these questions. I think in the emergency department, we're a little less scared because we ask hard questions every day. So we as a group are trying to figure out how to do something internally until we get sort of past this barrier of we don't have enough money to train the people and we don't have enough people trained. So that's what we're doing in our work group. That's what we're working on in the work group right now. I think more people being champions for this and just speaking up in your environment saying, hey, this is really important. Let's talk about how we can do this. Let's reach out to the trafficking work group and how we can help incorporate. We're going to try to partner with adolescent medicine and incorporate a lot of this into the HEDS assessment, like Dr. Greenbaum was talking about, that this is the place where we actually get a lot of this information that raises our, our eyebrows and to know that this kid is at risk. So we need more people is really the bottom line, to be interested, to be engaged, to help us problem solve when we come up against some of these problems. So I'd say that's my goal here today. And
Can I just add something? I think
yes,
what
please.
you mentioned of incorporating things into the HEDS exam is right on, that you may not want to have a specific tool, but you could incorporate many of the questions that are already in the HEDS exam. That alcohol use, for example,
Right.
is in the HEDS exam. So a lot of these are sensitive questions are perfectly suited for the HEDS when you're talking about more sensitive issues.
Yeah, I think
so. A lot of people do that.
Right. We have Epic, right, as our electronic medical record, and one of our colleagues is in charge of the Epic tool or whatever. So I talked to him yesterday actually about how to create a more robust HEDS exam that's a smart phrase, that it's a drop-down menu. It just raises awareness, because the more you look at these tools, the more you think about these risk factors, the more you identify these kids, right, which is the whole goal, is to try to get them services. So you have a question?
Thank you. This is such an important work. I want to say it was a great talk, but it was sort of a chilling talk, and this is very important work. I'm curious if you could talk a bit about outcomes for children who are identified and offered resources and accept resources? How many are able to sort of, I guess, get to a safe environment and remain in a safe environment? I'm struck by other healthcare scenarios where we implement like universal screening. It's because we think early identification will help make a big impact on outcomes. And so what do we know about the outcomes here?
Shannon, do you want to take that question or should I?
I'll give you this just in case.
I would say that I don't know that much about all the outcomes, honestly. I don't know if you know more about it. Sarah, do you have anything to say about, like, I know you followed some of these kids. Sarah Fenstermacher is a nurse practitioner who's online, and she tracks our data really robustly. Sarah, are you there? She's probably dropped off. Okay. Okay, Dr. Greenbaum, let's hear what you have to say about national statistics and what you know. Thank you.
Sure. I think that re-trafficking is very, very, very common, probably the rule more than the exception. That in many cases, children do not realize, they don't perceive themselves as being exploited. And so they are not necessarily wanting to accept services. So many times you may offer services and they don't follow up on that, which doesn't mean it's not worth offering the services. It's good to open the door and keep repeating that every time you see them. But we need to sort of be realistic and realize that in many cases, the child is going to return to the trafficking situation because they view that as the best situation that they have because their home situation is so bad. Or they honestly believe that the person who's trafficking them is, say, their lover and will bring a good life. The other thing is that even when children are removed and placed into care, say for 3 months in a residential treatment center, often when they are discharged, they're going back to their family environment, which has changed very little, if at all. And so all the same vulnerability and risk factors are there. And because the system just doesn't have the resources to really, really delve into family counseling and family resources, all too often children end up back in the same situation. And so it's not long before they run away again and get into the same situation. Or children who are in foster care are put back in foster care, they run away again. So I think that in many, many cases, and I don't have specific numbers, I'm sure it varies, but I think that we need to sort of assume that the child may be in a very high risk situation even after intervention. People, when you ask survivors, well, what finally made you get out of it? It's often adults at this point. They'll say, well, something major in my life changed. I had a child or something. I realized there was somebody else I need to take care of, or I finally realized that this was not, that the people were not looking out for me. There was some major shift in their view that allowed them to then sort of change the life course.
Makes sense. It's not just a one and done.
Hey, this is Sarah. Can you guys hear me? I was able to get unmuted.
Hi, Sarah.
Hi. I think another goal of ours in the emergency department is to let these children know that we are a safe landing place. And so especially the kids that we see that chronically live on the streets, and despite the services we offer each time, I think just by being open about it and by talking about it and letting them know that if they come to us, we're going to treat them with compassion and we're going to treat them with trauma-informed care. They keep coming back to us when they get sick, when they get scared. I mean, we had a 12-year-old that showed up off the streets on her own because she was tired of being on the streets. And, when I hear stories like that, I feel like we had seen her multiple times before, that we've done our job, that we are showing care and compassion, and minimally we are giving them a safe place to come when they are hurt or when they are scared. Because I don't think, which I know Dr. Greenbaum spoke to earlier, there's not a lot of data out there. It's not like substance use, which we know, I can't remember how many times you have to go to rehab before it usually sticks. But I would hope at each interaction when we offer services, right, at some point, maybe something will stick. But really just that goal of being a safe landing place.
Thank you. That's really nice to
Absolutely.
hear. Actually, those kids that come back over and over, that's a good sign, and we don't often think of it that way in the moment. There's a question online from Emily George. In line with what you referenced in terms of victims not identifying themselves as victims and thinking that this is their best option, how do you conceptualize breaking cycles when victims engage in recruitment of other youth, or when parents who were trafficked continue the cycle of violence by trafficking their kids? That's a rough question.
I can take a stab at that. I think that in the immediate, like when we're in the emergency department in the clinic, that we need to accept their view of not being exploited, so accept their perspective and explore that, rather than saying you're exploited. You may think you love this guy, but that's going to shut somebody down. So I think we need to explore their perspective and accept it, and then perhaps introduce an alternative perspective. I'm an outsider. I see things differently. Can I tell you how I see things? And I think it's a gradual process that through over time in therapy that a child is going to come to realize, and it's not something that happens immediately, probably with counseling, that they realize that maybe this isn't the way they perceive it. They are being exploited, and that this is not something that they want and can see the harm. And that would also apply to parents. Again, it's not something you can just say to a parent, this is a bad thing for you to be doing. We really have to sort of get to the root of what their perspectives are, why they feel that way, and then sort of begin to talk about some of the downsides of that, help them understand the downsides of it, and get motivated to change their view. Sarah or Shannon, do you have anything to add?
I think that's really profound, to just accept what they're saying, right? And not try to convince them that about your agenda. I think your slide about, we have all these things that we need to do. I am so guilty of that, right? Like, let's move let's move it along. I know how to fix it. Let me help you. Of course you're hungry. How can you not be, don't you want this turkey sandwich? I mean, it just feels like we have a lot of stuff that needs to get done. And you're right. We don't force kids to do things, especially in the middle of the night. I often work at night or early in the morning, and there's kids who've been there since, 11 p.m. and nothing, quote unquote, nothing has been done, right? That's not really true. Yeah. We have done something. We've provided them safe harbor. We've given them food, let them take a shower, warm blankets. Like, we have done some stuff. So I think not forcing it and hearing what they have to say and aligning with them is really the most important thing we can do.